Welcome to the second season of The Sound of IR, a podcast that seeks to educate aspiring interventional radiologists about the clinical practice of IR. I'm Ben Roush, a fourth-year medical student at Western Michigan University, Homer Stryker MD School of Medicine.
And I'm Hannah Clode, a second-year medical student at University of Miami Miller School of Medicine. We work with a great team of students, residents, and attendings using the Power podcast to explore topics in interventional radiology. As the host of today's episode, we hope you find it both educational and enjoyable.
We're very excited to introduce this next episode of The Sound of IR, in which Hannah and I will discuss uterine fibroid embolization with Dr. John Lipman. Dr. Lipman earned his medical degree from Georgetown University School of Medicine. He did his radiology residency at Brigham and Women's Hospital, and he did his vascular and interventional radiology fellowship at Yale.
Dr. Lipman is also the founder of the Atlanta Interventional Institute and Atlanta Fibroid Center. So this episode was super cool. I feel like it's something that we've never heard before in terms of how he managed to create his own practice and also how passionate he is about bringing IR to like a clinical realm. What do you think, Ben?
Yeah, I think his approach to interventional radiology is something I love. And I think it's similar to what we've seen before with other attendings in which they had a really great mentor teach them or show them what clinical IR can be. And then he took those ideas and applied them in his own way to the creation of the Atlanta Interventional Institute and the Fibroid Center.
Yeah, and I think it's really inspirational to see how he's been able to chase that passion for patient care and implement it and completely just run with that idea and transform it into his entirely own, his own way.
Yeah, and I think talking specifically about fibroids, which he did an incredible job explaining, you can see that passion as he talks about the disease process. And he also does a really good job of breaking things down in a way that's very understandable and explaining his principles by which he practices.
Absolutely, I agree. And as someone who doesn't really know a lot about UFE, this episode has really made it clear, and I think I can probably have a really articulate conversation with somebody about it after listening to it.
Absolutely. Now, here's our interview with Dr. Lipman.
Thank you so much, Dr. Lipman, for joining us today on The Sound of IR.
I appreciate you having me on. It's great.
So to start with, we'd like to know how you became interested in IR and what your journey was into the field.
Well, I was doing radiology, a lot of electives in it. I was interested in it. I liked the problem-solving aspect of it. And while I was a medical student at Georgetown, I had heard about a interventional radiologist that was doing some amazing work in this small suburban hospital in Virginia. And so I reached out to him and asked him if I could do an elective during medical school with him, and he sounded rather flattered that I knew about his work, and he said absolutely. And when I spent some time with him, it was clear that this is somebody that I wanted to be like. And so this early mentorship, I think, is really important. And as it turns out, he became, he's iconic in interventional radiology. It's Barry Katzen.
Oh, wow.
He's just an absolute icon. But at the time, he was, working in a small suburban hospital in Virginia, just doing amazing stuff, and I got exposed to him early on, and that was it. I knew what I wanted to be. And that's why mentoring is so important. And we try to mentor people as well, because we want people to go into IR. It's the coolest medical specialty there is. And it's something that a lot of people don't know about. And they should really check it out because it's fabulous.
Wow. I can't imagine picking a better mentor at the time.
I was very fortunate. I didn't know, who he was. I just heard, and it was, wow. It was, the light bulb went off.
That's amazing. Actually, his practice that was there in Alexandria, we've had one of the attendings from that practice here on the podcast, Dr. Vadlamudi. He's one of the young attendings in what I believe at that time was what is now that Alexandria practice.
Yeah, they've kept on the tradition, even though he is no longer there. Arena Van Breda was the other person there, and she's, an icon in her own right, one of the early pioneers and one of the few women in IR, and truly an amazing IR in her own right. She's still there and has kept the tradition of just outstanding people that work there. Keith Sterling, who's kind of my age and is a phenomenal IR, and they've had a number of outstanding people that have been there and still are there, and they've trained a lot of people.
Yeah, that's awesome. So when you went and spent time with him, was it kind of like you saw what he was doing and you were just sold? You knew that's what you wanted to do?
Immediately. It was so cool. Doing things with IR, performing these amazing procedures all over the body and caring for people in such a way that you can do things without open surgery. It was the coolest thing ever, and it's been great. I'm so glad I was exposed to him because I'm not sure what I would have become otherwise. Probably some sort of surgical specialist, but I'm glad I met and got the chance to work with Barry.
That's amazing. So from there, you were sold. You decided to go into training and become an interventional radiologist. As you finished your training, what decisions did you make about how you're going to practice, and what's led you to the way your practice is set up today?
Well, after training, I knew, obviously I had done interventional radiology fellowship, and I came to Atlanta. They were looking for an IR at a very well-respected hospital in Atlanta. And so I started my journey there. And after a while of working there, there was something that just wasn't right. It was how interventional radiologist was practiced, and unfortunately is in some places is still being practiced today. Is that you kind of you are a consultant for other physicians, and you kind of just wait for them to have an issue and then refer somebody to you. Versus having your own practice, your own clinic, and being able to care for patients and be involved in their longitudinal care. It's kind of the difference between a proceduralist and a clinician. Mm-hmm. And I was, at the time, and that when I came out of my training, I felt that, I had been trained in a clinical model. I had worked in my fellowship with Dr. White at Yale, and he was very strong in clinical, having your own clinic. And so it became kind of almost confrontational with my practice, because I wanted a clinic and to care for patients.
Yeah.
And they wanted me to read films when I wasn't doing, IR cases. And the clinic model is so important. And so it became, after a while, even though they did agree to kind of a hybrid clinic, it really wasn't what I wanted. And I wasn't happy about what I was doing and where I was. And so I struck out on my own and had my own practice, my own clinic. And I wish I would have had the nerve, several years earlier, because it's difficult. You're comfortable, you make a decent living, you have you're working at a well thought of hospital and all the trappings and all the comfort, but it's not how you want to practice. It's not how IR should be practiced. And I'm so glad that I took the jump, and it was the second best thing I've ever done. So it was the right thing to do. I knew in my gut it was right, but it's not an easy thing to do.
Yeah, definitely. It seems too that the first IR you were exposed to with Dr. Katzen was in that model. We've had Dr. Swisschuk, who's from IU Peoria, who had seen that model at Miami Vascular and emulated that in setting up his academic practice and their training in Peoria. And so it seems like those that are exposed to that clinical model try and emulate that in whatever way they see fit later on.
Yep, it's so important. And now it's more commonplace, and really it's become the standard. There are some places that try to do the old way, but that's just it's not how medicine should be practiced.
Definitely.
Yeah, I was going to say, it seems like now there's more of a push towards the clinical IR. So it's not as revolutionary. It's almost a little bit expected. And I think it's a good move for the specialty. But back then, it seems like that was kind of novel for the field?
Oh yeah, it was very novel. In fact, I spent a lot of time talking at our national meeting, the SIR, Society of Interventional Radiology, at their national meeting. I would be, one of the speakers speaking on, the importance of clinical IR, the importance of setting up a practice, because there's not many, even to this day, there's very few solo IRs around,
So that kind of brings me to another question we had for you is, what is the pro of having your own solo IR practice? What are some of the liberties that you can take because it is just you?
Well, and it has been me for almost 14 years now, but I have the pleasure of just recently, last month, hiring a colleague. And so I'm really excited about, having her on board. And so I'm no longer solo, but that's a recent development. And, just excited to have her join me because, it's time. It's definitely time for me to continue the growth of the practice and to continue doing what we're doing. And she's, I think, going to be a phenomenal addition. But we're still small, obviously, and small has a lot of advantages. We can be very nimble. A lot of organizations, my previous practice, we would have what I call, paralysis through analysis. I mean, everybody in the group, and we had a lot more diagnostic radiologists than IRs. So we got outvoted every time on key issues, which is, again, one of the reasons why I left. But everybody had an opinion and everybody had to have a vote. And it's like that organizations can't move forward if everybody's got to weigh in and you've got to satisfy everybody, and so now we can be nimble, we can address things quickly, we can move on a dime versus trying to steer a super tanker.
Yeah, that's interesting. So I've heard several different IR attendings talk about that, the issues between DR and IR, but as you have become independent, how have you been able to get the patients that you want and also practice in hospitals or whatever other ways you've set up your practice?
Well, I think the most important thing is to first decide kind of what you want to do. What are the types of patients that, give you joy? I mean, when I was, again, using my previous practice in a community IR setting, there were always patients that I really enjoyed seeing and I really thought I could really be helpful to them. And there are other types of patients I really almost loathe to see. And, you don't have to be the master of everything, no matter what specialty you are. You don't have to be the expert on everything and you don't have to do everything. I think that's kind of an older model. I enjoyed seeing fibroid patients. The procedure, the UFE procedure, uterine fibroid embolization, is one of the biggest medical breakthroughs of all time. In terms of medical significance, I would put it up there with the mammogram and the pap smear. And yet, even though I've been doing this procedure almost 25 years now, it's still relatively unknown, which is tragic because they say it's such a huge breakthrough. So I decided I wanted to see those types of patients and built my practice around women's health and fibroid patients. And those are the types of patients I enjoy seeing. And so my practice is really niche-y. It's not only is it within IR, which is a subspecialty of radiology, I'm even nichier than that because my field is just pretty much, we serve women, either conditions that are seen exclusively in women, and we're most known for our work in uterine fibroids, but we also do female infertility. We see migraine patients because migraines are primarily women, varicose vein work, and even osteoporotic compression fractures, which are seen predominantly in women. So it's at least predominantly in women conditions or exclusively in women.
Interesting. So what was the decision to build your own center versus continue to work out of lots of different hospitals, or do you still do both?
Well, no, I pretty much left the hospital life behind, which is really a welcome relief. Hospitals are they're so inefficient, they're filthy, and they're inconvenient. You know, patients, when I worked at my previous hospital, which is very well thought of and, near downtown Atlanta, it was very difficult for patients to get to me. And once they, because this one road that led to the hospital was always congested. Patients were always running late. And they were angry once they got there because not only were they late, but we couldn't get the hospital to validate parking, if you can believe it.
Oh, wow.
And so they had to pay for parking, and they had to walk about a mile to get to where my office is on the grounds of the hospital. And so they would come late and they'd be upset. And it just started, kind of a negative ball rolling, if you will. Versus now, my patients who come to see me, they pull right up to the front door. It's very convenient. We see them immediately. There's not this log jam of other types of people. It's so nice. And to say, we try to make the experience as pleasant as possible. We want that Four Seasons, Ritz-Carlton experience in healthcare, which patients will all the time, tell me commonly, they can't believe the experience they had. And everybody that they come in contact with in my organization, another benefit of me versus the hospital is I hire everyone versus in the hospital, there were people that were miserable. They hated their job, and I could, and they were all a reflection of me. Mm-hmm. And so even though I didn't have any control over these people in the hospital, they were, if they were upset and they didn't care, it was very evident. And the patients that come to see me thought, well, wow, he works for Dr. Lipman or she works for Dr. Lipman, and they're, this was really bad. Versus now, I hire people for their HQ, not their IQ. We talk about this all the time. And HQ is hospitality quotient. Yeah. It's the measure of how someone derives pleasure from pleasing other people. And so I can teach them the few things I need to teach them about their day-to-day job, but what I can't teach them is what they already have or they don't have, and that's HQ. And so I control the entire operation. Everybody that comes in contact with my patients, is just the best, most positive person you've ever met. It's a thrill to come to work. I love coming to work every day. We do a great job, and that positivity just grows upon itself. The patients come in and they're greeted with a smiley, happy, positive person. And that just transcends the organization. Every patient has one-to-one nursing. Again, something that can never be done at a hospital. Yeah. Every patient has their own nurse throughout the entire process until they leave. It's a joy. You should come and visit.
Yeah. It's interesting because I've rotated on IR. I've gone on interviews for IR and DR. And what I've seen is often the IR suites are buried deep in the hospital. But then, there's parts of radiology like mammography is usually its own separate area. It's tried to be made a little nicer. And they might have different staff and whatnot. But you'd think that a procedure like, fibroids or something else would be given the same sort of treatment or formatting as something like mammography.
Yeah, unfortunately, it hasn't in the past. It's been kind of, as you say, kind of in the dungeons. That's where, IR has been done. In fact, they even called it special procedures. I always hated that name. It's like, what is specials? What is that? So finally, we're getting a face. IR is finally being recognized as a specialty. In fact, it's timely that the interview, is this month, January, because January 16th is National Without a Scalpel Day. It's the anniversary of Charles Dotter performing the first angioplasty in Portland, Oregon, many years ago.
Mm-hmm. Oh, wow.
That's awesome.
Man, I just have to say, this is incredible to hear the way that you saw that there was a gap in what you thought patient care should look like and what you were seeing in front of you, and you attacked it and changed it completely, turned it on its head, and you have such positive results, and how you're talking about your patients are just in so much better moods. And there's so many studies about the power of positivity and health outcomes. And I think it's just amazing what you're doing. That's awesome.
Oh, thanks. as I say, I love what I do. I hope I can do it for a long time.
So talking about the patient population that you love treating, can you talk a little bit more about what types of patients these are and how they present, and sort of what are the basic issues that they're coming to you for?
Sure. The most common patient that will come to our practice is women that are suffering with symptomatic uterine fibroids. Fibroids are very common in women, particularly women of color. Up to 80% of African American adult women have these benign tumors.
Wow.
And while they're benign, they can cause a lot of misery.
Mm-hmm.
It's the most common reason why women have heavy periods. And sometimes these women don't even know what they're doing each month is heavy, which is surprising. I mean, because they've just been doing it for so long.
Mm-hmm.
They're just bleeding miserably. Blood will just explode and run down their legs, and they're wearing all sorts of extra padding, extra gear, extra clothes. They may even come to my office with a bag of, extra clothing. They're afraid to, sleep in, on certain linens or sit in certain chairs because it's that time of the month.
Yeah.
They, a couple, 2-3 days out of the month, they may be out of commission entirely, maybe not even able to work.
Wow.
Because of these heavy episodes. They have to know where every bathroom is. Their whole life is kind of revolved around their menstrual, and it's miserable. And a number of them are anemic because when you lose this kind of blood every month, you can't possibly replace the iron and hemoglobin that goes with it.
Yep.
And so they become tired, they're weak, they may get lightheaded or dizzy, migraine-like headaches. They will often chew or crave ice. When I ask them about that, they look at me like, wow, you're clairvoyant. How did you know? But those are all signs of, clinical anemia, which we can correct very easily with UFE and give these patients their life back. So they come into our practice tired and weak and worn out, physically and mentally drained. And then after the UFE procedure, when I see them in follow-up, they're transformed. They're a new woman. We hug. They're just thrilled. They got their life back. They're very appreciative, and they want to tell everybody that they know.
So some of our listeners probably know a lot about uterine fibroid embolization and fibroids in general. Others don't. And so can you break down the basics of what the different types of fibroids are and what are the risk factors for development?
So there are essentially 3 areas in the uterus where fibroids are located. There are ones that are up against the lining, the submucosal fibroids, and those are the ones that typically cause the heavy bleeding that we were just talking about.
Mm-hmm.
There are ones that are located underneath the outer covering of the uterus. Those are called subserosal fibroids. Those are more involved in bulk-related symptoms. They press on nerves to cause pain in the pelvic region, back, buttock, even down the legs. It can mimic sciatica. And the ones in between are the most common, the intramural ones, the ones that are kind of in the muscular part of the uterus. They can, depending on which way they grow, if they grow toward the cavity of the uterus, they tend to cause more bleeding symptoms like the submucosal variety. Or if they grow outwardly, they tend to cause more bulk-related symptoms like the subserosal variety. Or they can do both. If they're big enough, they can grow in both directions and cause both. So those are the different types. And then if they're symptomatic enough, and you basically talk to patients about their symptoms, and then you look at their imaging. And we use MRI imaging. It's the gold standard of evaluating fibroid patients. A number of them have had ultrasound, but ultrasound doesn't have the resolution necessary to really evaluate these patients. And I commonly see women who are misdiagnosed as having fibroids that don't have fibroids at all. They have another condition called adenomyosis, which also causes heavy bleeding and pelvic pain. And we can talk about adenomyosis later on. But so they'll come to me and they'll have symptoms of fibroids, and then we look at their imaging and we put it together if it makes sense. So if a woman has symptomatic fibroids and her imaging makes sense, these fibroids are located in areas that we just mentioned that fit her symptoms, then she's a candidate for embolization. But there are some patients that like a patient might come into me for heavy periods and heavy bleeding, but they don't have any fibroids that are anywhere near the lining. They may have some small subserosal fibroids. So she has heavy periods and she has some tiny fibroids, but it doesn't make sense. The embolization is not going to help her. We need to look further. And that's why it's so important to be a clinician, not a proceduralist, because in that kind of scenario, they're not a candidate for embolization. We would do a saline sonohysterogram in the office and likely find out she has an endometrial polyp that the gynecologist can remove very simply in their office.
So when these patients are coming to you, some have a diagnosis from a different doctor and some are coming to you without having any history of seeing any doctor?
Well, most patients have seen a doctor, whether it's a primary care physician or a gynecologist. Occasionally, somebody hasn't seen their gynecologist and has a diagnosis of fibroids, and they're what we call the silent sufferers. They sit on the sidelines. There's over 1 million women in the United States that have a diagnosis of fibroids, have horrible symptoms, yet the only option given to them is a hysterectomy, and they don't want it, and I don't blame them, but they don't know about UFE, so they kind of suffer with the symptoms and suffer with fibroids until all of a sudden they hear about UFE and they hear about the work we're doing, and they're like, wow, what, and they come in and they're like, why didn't we know about this? And I said, we've been doing this procedure well over 20 years, almost 25 years. Unfortunately, many physicians won't tell you about it. It's unfortunate, but they don't. They'll only mention the surgical options. And that's why we spend a lot of time in the community educating physicians about UFE and about the treatment, the non-surgical treatment of fibroids.
So you mentioned these more subserosal fibroids as ones you can't treat very well. Are there other types that are difficult to treat or certain burdens of fibroids that make it more difficult to treat?
Well, we'll treat patients that have subserosal fibroids. It's just in those patients, they're not causing heavy bleeding. They're causing bulk-related symptoms, depending. So we'll treat patients that have subserosal fibroids, absolutely. In fact, if you suffer with uterine fibroids and if you're told that you need surgery, almost every patient is a candidate for embolization. And that's why, again, it's so important to get a second opinion. No matter what you've been told by your gynecologist, you need to get a second opinion from an experienced interventional radiologist that treats fibroids to see if you're a candidate for UFE.
Interesting. And so what is the age range that you usually see in these patients of yours?
Well, patients will develop fibroids even in their 20s. We try as best we can not to treat patients, that young. We're really conservative about treatment methods, and we'll start with kind of things that we can modify behavior, for instance, and diet and exercise, which are really important. One of the reasons why African American women disproportionately suffer with fibroids is that in general, they have more body fat than other racial groups. If you look at body fat distribution and fibroid distribution, they're basically identical by race. The highest is African American and the lowest is Asian. Now, nobody knows where fibroids come from, but once they arrive on the scene, we know they grow with hormones, particularly estrogen. And estrogen is stored in fat, and the more body fat you have on you, the more stimulated, your fibroids are going to become, and the more likely they're going to grow rapidly and develop symptoms earlier on. And if you look at African American women, you see that they get fibroids earlier in life, they get them bigger and more numerous, and they're more likely to get surgery. And those patients can all be saved from surgery if they know about UFE.
So are there any sort of diagnostic studies that you guys do prior to the actual embolization to figure out maybe outcomes or how heavily the risk factors are impacting what could potentially be an adverse outcome?
Yeah, the imaging we rely on is the MRI. I mean, while a number of these patients have had ultrasound, as I mentioned, the ultrasound just doesn't give you the resolution. In fact, commonly patients will say, well, I know I have 2 fibroids. We've been following for them for a long time, and now they're really starting to bother me. and we do the MRI and there's 15 or 20 fibroids.
Oh, wow.
And they're like, well,
Wow.
where'd they all come from? It's like, well, they've always been there. It's just the ultrasound doesn't have the resolution to see them as well. And as I say, also, we'll discover patients that have adenomyosis, which sometimes it coexists with fibroids, and sometimes it's the only diagnosis. There are no fibroids. And wow, if you want to see a patient looking perplexed, it's ones that, and I've seen this fairly commonly, they come into the office with a long history of fibroid diagnosis, and then I have to tell them they have no fibroids at all, and they have this other condition called adenomyosis.
So while we're talking about adenomyosis, is there a role for embolization with adenomyosis, in your opinion?
Absolutely, there is. And it's really important because there's really only two things that work for adenomyosis. Hysterectomy works, but it's obviously very severe and extreme, and embolization works. It doesn't work quite as well as it does for fibroids. I mean, the success for fibroids is around 90%. The success for adenomyosis is more like 75%, but it's getting better. We're refining the techniques of embolization, doing a little bit different techniques for adenomyosis and getting a little bit better success more recently. But it's very important to know what you're dealing with, obviously, and patients that have, they're thinking they have fibroids, and now you have to tell them they have this different diagnosis. It's a lengthier conversation. And where it becomes particularly relevant is that if patients think they have fibroids, and if they have either a definite or possible desire for fertility, they're going to be offered a myomectomy surgical procedure, which is cutting out some of the fibroids surgically and sewing the uterus back together. Well, in patients that don't have any fibroids and have adenomyosis, there is no myomectomy option. So women can get cut open surgically, and all of a sudden the surgeon goes, uh-oh, now what? And so there's basically two choices. Either close the patient and wake them up and explain to them they've made a mistake, or there is a complication, they got into too much bleeding, and a hysterectomy was necessary. And I will leave it to you how that goes.
Yeah, that's difficult. And so that kind of begs the question about fertility in general with both embolization and other methods. So with a myomectomy, while we're on the surgical topics, what are the chances of fertility after myomectomy and complication rates with pregnancy with myomectomy?
For after myomectomy, if it's with an average fibroid burden in a young patient, they have about a 50% chance of having a child after a myomectomy. In my opinion, there's never a reason to do a second myomectomy, but I've seen lots of women that have had 2 and 3 myomectomies, some as many as 5 myomectomies, and then they're coming to see me. I think that, in my opinion, that's malpractice, but I don't think there's ever a reason to do a second myomectomy, because after 2 myomectomies, there's very little fertility left. And clearly you have a problem with numerous fibroids that you can't address surgically. Now you're putting a third procedure in front of these patients. And so anyone that's ever had a myomectomy, if they ever suffer with fibroid symptoms, in my opinion, those patients should all get UFE and UFE only.
Yeah, interesting.
So how does myomectomy fertility outcome compare with UFE fertility?
Well, they're comparable. I would say it's been very poorly studied because the patients in general in the trials that have looked at it, the UFE arm of the trial, those patients tend to be older, sometimes significantly older than the myomectomy arm. And,
interesting.
And age drops your fertility. In fact, some of the trials, I was surprised UFE did as well as it did. It came up a little short compared to myomectomy, but when you look at the age differences, I mean, some of these trials were like 7-year average difference in age, which really affects fertility. So
absolutely,
I think you can expect about a 60% fertility after UFE, but the trials that have been done to date have been really poorly done. Hopefully we'll get some better trials If you have a myomectomy, you're going to have to get a C-section. Our patients that have had UFE, the patients that have had children afterwards, typically they're full-term and vaginal births.
Wow.
Again,
that's a huge difference.
It's really big. I mean, these patients that are getting myomectomies and then getting C-sections, the multiplicity of surgeries that are done. Mm-hmm. In fact, the two most common surgeries done in the United States, one is C-section, two is hysterectomy for fibroids.
Jeez.
Oh, wow.
It's a multi-billion-dollar industry, hysterectomy. And the average age of hysterectomy in this country is less than 40. And I've seen a lot of 20-year-olds, women in their 20s, have already had a hysterectomy. They didn't want it. In fact, I was speaking at Tuskegee University not long ago and met a 26-year-old who was devastated when she heard my talk on UFE. She was in tears because she sought 3 GYN opinions. All 3 said she needed hysterectomy for fibroids, and she didn't. And now, not only is she not going to have children ever, she's a different woman. She goes, I feel like I'm an old lady. It's wrecked my life. Hormone are out of whack. I have no libido. And she was just devastated. And it's just, you don't have to have that. You can get the relief of symptoms from fibroids without any surgery, and importantly, keep your parts. I think the importance of keeping one's uterus is really undervalued by a lot of physicians, and that's really sad.
Yeah. It's a difficult story to hear of these young people, or just anyone losing an organ, a vital organ of theirs that they don't want to lose. You mentioned some of those side effects that happen after a hysterectomy.
Yep. Well, first of all, there's the surgical complications.
Yeah.
Nicking the bowel, nicking ureter, nicking bladder. We saw a relative of a patient. The one sister came in to see us for a UFE after her sister got first a temporary and then a permanent colostomy from her hysterectomy surgery. And so it was really devastating. But there are a number of surgical complications, most commonly transfusion. That's probably 30% of patients have bleeding and transfusion issues. And then the surgical complications, which are usually something fixable, but again, either more surgery or calling an interventional radiologist to bail out whatever happened, either a pelvic abscess or divert the urine with a nephrostomy or what have you.
So that brings up a good question of what are the side effects of having a hysterectomy on a woman that's young or just in general?
Well, in general, there are a number of important functions that the uterus has besides simple childbearing. I'm always amazed at the gynecologists' underappreciation of the uterus, particularly female gynecologists. A lot of times women that are struggling with fibroids, are told just have a hysterectomy, they're done having their kids, and you just don't need your uterus anymore. And that's just plain absurd. The uterus is obviously the epicenter of a woman. It's, a number of women struggle psychologically after having a hysterectomy, like a man being castrated. Mm-hmm. There's lots of sexual dysfunction after hysterectomy, and it's an embarrassing thing to talk about, but it's real and it's not an insignificant thing. And the average age of hysterectomy in this country is less than 40.
Unbelievable.
So these are young women, and I've seen way too many women lose their uterus less than 30.
Wow.
Which is tragic. I have daughters that age. So we have to be more respectful. The uterus, it's important psychologically, it's important sexually. Women go through loss of libido, loss of orgasm, other sexual dysfunction. We know the uterus is important for bone health. Women who have hysterectomies have a much higher incidence of bone loss, which again leads to osteopenia, osteoporosis, and then could end up, with vertebral compression fractures and other the side effects of having significant osteoporosis. And then lastly, there's pretty good evidence to suggest it's important in heart health. The uterus produces prostacyclin. In fact, it's one of the largest producers of prostacyclin in the body, which is a very potent vasodilator. And there's this kind of balance between vasodilators like prostacyclin and the thromboxanes, which are more vasoconstrictors. And it's felt that women who have hysterectomies, particularly less than age 50, have a much higher incidence of atherosclerotic coronary disease, hypertension, stroke. And while that was kind of a surprising thing, what does the uterus have to do with cardiovascular health? This connection with prostacyclin is an interesting one. And if you're left in kind of relative vasoconstriction because you've lost this producer of vasodilatation, maybe that does impact your cardiovascular health. So the bottom line is it's just not necessary. You don't have to lose your uterus over a benign tumor. We started a campaign not that long ago called Don't Lose Your You. Don't lose you are you, meaning don't lose your uterus over fibroids. And we have had a number of people get on board with it. Cynthia Bailey from The Real Housewives, who was a patient, has been a strong advocate for the Don't Lose Your You hashtag. We got the former First Lady of Atlanta, Sarah Elizabeth Reed, who's been a very outspoken advocate for it. And we're trying to use the hashtags throughout our social media campaigns and trying to just raise awareness that, women who are suffering with fibroids don't need to undergo hysterectomy. UFE has been a real godsend and just a tremendous breakthrough for women. The biggest issue is that most women struggling with it don't know about it.
I think that's amazing what you guys are doing. I mean, obviously in the individual lives of your patients, but in addition, the awareness that you're bringing to this procedure, like you said, most people don't even know about it. So I think it's incredible that you guys are spreading the word and really taking an aggressive approach into showing other people what you guys can do for them. I think that's great.
Well, it's just gratifying to see, patients that have had the UFE, tell us, how it's just transformed their lives. I mean, these women oftentimes are just struggling so miserably. In fact, these women are often anemic, they're weak, they're tired, and they're just worn out physically, mentally. And we have the solution. UFE is a tremendous option. They just don't know it exists. And, we continue to be amazed that even though we've been doing this procedure almost 25 years now, it's still relatively unknown. And it's a real shame because it's one of the biggest medical breakthroughs for women.
Yeah, I completely agree. So we've been talking a lot about UAE, but we haven't actually delved into the details of it. So can you tell us a little bit about the procedure, maybe step by step for our listeners who have never heard of UFE?
Yep. So the procedure, uterine artery embolization or uterine fibroid embolization, it's the same procedure. It's done from primarily one of two approaches, either the femoral approach, which is at the top of the right leg, or a radial approach, which is usually the left wrist. It's just an entry point into the body, done with local anesthetic. So once you've anesthetized the skin and you've entered, now you're just taking a catheter over a guide wire and traveling selectively into each uterine artery. The uterine arteries branch like a tree, getting smaller and smaller branches. The fibroids are the leaves of the tree. We know what size these peripheral branches that feed all of the fibroids, we know what size they are. The target is somewhere in the 500 to 700 micron size. And to give you an idea what that means, a red blood cell is about 7 or 8 microns, so it's roughly 90 to 100 times the size of a red blood cell. That's our target. And we have embolic material that can plug up the vessels for that size. And there are two main embolics used. They're both permanent agents. One is polyvinyl alcohol, PVA. That's the one that has been used the longest. And the size for PVA typically is 355 to 500, and then upsizing from there, because we start a little smaller with PVA because PVA is kind of irregular. If you looked at PVA under the microscope, you'd see these kind of jagged, irregular particles, and they tend to clump. And so the effective size is actually going to be larger because it tends to aggregate. And so we'll start with 355 to 500 micron PVA. And as necessary, if we need to, we can always upsize to 500 to 710, or even 710 to 1,000 micron for the really big fibroids that are taking a lot of embolic to kind of slow down. You want to basically knock out this blood supply to each and every fibroid. And if the other embolic that's commonly used is what's called embospheres from Merit Medical. It's an acrylic bead embedded in gelatin, and these are spheres that are fairly tightly calibrated and are basically will pack like marbles in a cylinder. So unlike the PVA, which is more irregular and tends to clump, these things stack like marbles, and they're very tightly calibrated. And so depending on what you believe, some people like the elegance of a more tailored spherical particle, and other people are more traditional and use the standard PVA. But now there's an even newer embolic class, the ones that are, that break down over time and are not permanent. And those are coming to market now.
Oh, interesting. So I guess a question for you, Dr. Lipman, which embolic do you prefer?
Well, I use several different ones for several different purposes. I would say the workhorse these days has been polyvinyl alcohol for me. Mm-hmm. We do use, the Embosphere product as well. Those are what we use most commonly. And now for patients that are interested in fertility, either definitely or possibly, I'm using the degradable microspheres for those patients. We don't know if that will have a positive impact on fertility. We just have to wait and see, but that's the idea, that for that embolic, it will block the vessels, it will cause the fibroids to infarct and die, and then it will break down and disappear and won't leave a permanent footprint that potentially could impact in some way somebody's ability to have a child. So intuitively, we like the fact that these spheres break down and disappear. It's aesthetically nice, but whether that translates into any real clinical benefit, we don't know at this point.
Interesting. So to help our listeners that might not fully understand the concepts behind embolization, I guess the best way to phrase this question would be, if there's a student listening to this right now thinking, okay, well, all right, we're trying to embolize these fibroids. Why wouldn't it be better to either have smaller embolics to get farther into the arterial system, or B, do more embolics to further block this system and have more infarction and have more shrinkage?
There's a couple of things in there. You have to be careful because you want to selectively kill the fibroid, but you don't want to kill the uterus. Mm-hmm. So if you were to use particle sizes that were smaller, you would risk, infarcting the uterus. And unfortunately, in Europe, that was done on several occasions until they realized that they had some very bad outcomes from that. And so you want to be careful. You'd say your target is 500 to 700 microns. And if you're using a calibrated, spherical embolic, you want to be in that size range. If you're using PVA, say a little bit smaller, because it aggregates and you get an effective size range around 500 or so microns, which is where you want to be. For adenomyosis, just to add that to the mix, that's where we often use a smaller particle size. We will use 250 to 355 PVA, the next lowest size. Or if we were using embospheres, we would use 500 micron embospheres. Again, and for adenomyosis, not only we're using a slightly smaller particle size and not upsized, we also go to stasis, which is we want to really shut down the flow, if you will, has shown to be a way to get a higher result without any undue, side effect or complication.
So is that specific to adenomyosis, that stasis?
Yeah, that is for adeno, at least in our practice it is.
Uh-huh.
If we're doing just fibroids alone, we won't be as aggressive as an endpoint as we are for adenomyosis. It'll be a less aggressive endpoint, a very slow, choppy forward flow in the uterine artery. Some people count out cardiac beats, but as long as it's a very slow, choppy forward flow, I don't think you have to count out how many beats it takes for the stuff to disappear. But for adeno, we are more aggressive, and it's really a much slower, a static flow for that. But you have to kind of remember to keep the right sizes in mind, because you don't want to be too small, because then you'll start getting, infarctions of the uterus, which would be very bad, obviously.
So the badness of that, is that causing more pain for these patients as well?
More pain and permanent damage to the uterus.
Yeah.
Which you don't want to do in any patient, whether they're family complete or not. You want them, you want to knock out the fibroids.
Exactly.
The uterus.
So the reason I ask these questions, both for our listeners and also to further this discussion, is often, I've either seen cases on social media that are brought up or in other forms where people are putting in a lot of embolic, vials and vials and vials in these uterine arteries for fibroids. And so the way you explain it sounds a little more conservative. So what's the downside, not of downsizing embolics, but of just putting more embolics?
Well, whenever I see these, and I've seen what you're talking about, I've seen on social media where there was someone that, was proud of the fact that they put in like 26 or 27 syringes of embolic into a patient. They had them all lined up on a sterile towel and kind of preloaded in syringes with different colors based on the sizes. So it was a very colorful display until you realize that's a lot of embolic, which is permanent, that you're placing inside of a patient. And so it was really kind of upsetting, to see this, because it was kind of callous, and, you have a responsibility to the patient, and it's something that's just completely unnecessary. I've done over 7,000 UFEs. I've never had to put that many syringes in. And the way you avoid that, and you can still get an outstanding result, not to mention the cost of putting in that much embolic.
Oh, yeah.
You start at 500. Let's say we're using, and typically when you see these pictures, it's with embospheres. So you start with 500 to 700 micron embospheres, and you might put in 3 syringes of that maybe, and then you kind of gauge how the flow is going. And if it's a patient that has huge fibroids, and the flow is still really strong, you haven't really slowed down anything yet, you upsize and you go to 700 to 900 micron embospheres, and then you might put in 2 more of those. So now you're at 5. Mm-hmm. And then if it's still pretty strong and it doesn't seem like your endpoint's anywhere close, I go to 710 to 1,000 micron PVA, knowing that it's going to clump, and that effective size is even greater than 700. It's getting around 1,000 microns now, and you will slow down the flow and get a very nice result. You've knocked out the target, the 500 to 700 micron vessels with your earlier stuff. Now you're just kind of slowing it down to get to your endpoint quicker. And it works very, very well, this technique. And you might use at most like 7 total syringes on a side, at most, maybe 8. I think I've done a few 8s on one side in my 7,000 plus, but it's very unusual. Most cases are done with either 2 syringes on a side, or if you're using vials of PVA, 1 or 2 vials of PVA on a side. That was a pretty typical amount. So you don't have this humongous load of embolic permanently in a woman's uterus for the rest of her life. And it's just not necessary. It's wasteful. It costs a lot of money that doesn't have to be spent. It's just, on all fronts, it's just not necessary.
So the main takeaway is basically the better technique would be to start out small and then gradually get larger. That way you're not just pumping in a lot of small embospheres.
I mean, if you have a really big fibroid, patient with a really large fibroid burden, and you're just using 500 to 700 micron embospheres, you can go like 20, 25 syringes of that. I mean, that's just wasteful. Plus, one other thing that when you're doing this, you have to kind of realize there are some patients that might have an arteriovenous malformation. And you better know what you're dealing with and making sure that it's fibroids and not a pelvic AVM, because you start injecting embolic in an AVM of the pelvis, you'll get it across the other side and have a really bad outcome. In fact, there have been, deaths reported from that very event. So you first have to understand what you're dealing with and get, very good imaging, making sure that you are dealing with fibroids or adenomyosis and not a pelvic AVM, because that's the last thing you want to do is start pumping in lots of embolic across an AVM.
Right. So I definitely want to get back to some of the side effects and post-op treatment or post-op procedures for the UFE patients. But I do want to revisit the idea of the biodegradable beads that you were talking about before. I've never heard of that, and that sounds really interesting. So the first thing that came to my mind, though, when you mentioned that was, what if they break down, like, quote unquote, too soon before the fibroids have actually necrosed? What happens then, and what are the other potential side effects of these new products?
Well, that's a great question, because it's something that we've never had to think about before, because in the past, when we're dealing with the permanent embolics, we're not worried about what happens to them when they break down. They stay there permanently. They're at a certain size. But now with these biodegradable spheres that start to degrade and break down, their breakdown products are smaller than, the original size. And will that have any effect? What happens when these things, now you're in a sense getting smaller embolic? Will that, cross to the other side? Will that, what's the impact of these smaller temporary, but still, while they're still around, they're acting like a smaller embolic? Will that have any impact on your target, whether it's the uterus or if you're using somewhere else? And so we've never had to think about that. And that's why it's taken a while for these things to kind of reach the market. And we've got to be thoughtful and make sure that there isn't going to be any kind of negative impact of using these things. That's the last thing we'd want to do. But it has a nice feature, the whole idea of something working, and then once its job is done to dissolve is, that's the ideal embolic. We are using, say, one of the ones that's on the market. It's a product by Medtronic that was originally a different company, Vascular Solutions, and it's been around for a while. So we felt that it had a long track record, even though it's kind of a more recent thing. It's been available for some time. We felt that was something where we could kind of test out the waters here and see if this is going to be the next wave as we think.
Interesting.
So what's the thought process in choosing the type of material that you're going to inject?
For us, it's, what are we trying to accomplish? If we're treating adenomyosis, as I say, we'll use a smaller particle and we'll go to a farther, a much slower endpoint. If we're doing fibroids, it's a different endpoint, and we're using primarily PVA. If it's somebody that's interested in fertility, we're using this, degradable product. So it really depends. Are we treating fibroids primarily or exclusively? Are we treating adenomyosis primarily or exclusively? Or is the patient patient that may be interested in fertility? So the different questions we're trying to answer, and will kind of dictate which of the embolics we like to use.
Interesting. So we described the procedure and getting to stasis or getting to slowing the arterial flow with these embolics. I know in some centers it's common to use either intraarterial lidocaine or intraarterial ibuprofen or other NSAIDs either before or during or after the embolic is given. Can you explain what sort of the thought process is with those options?
Oh, sure. We use intraarterial lidocaine after we finished embolizing one particular side. So we have a microcatheter in the uterine artery, and we're embolizing that side's supply. And when we're finished embolizing and we got to the right endpoint, we will then add 5 cc's of 1% preservative-free lidocaine intraarterially when we're done with that side. And we'll do that obviously on the other side when we're finished with the second side too. And that's really, really important. I think it's one of the most helpful things that you can do for post-procedural pain control. And we perform all these procedures. All of our UFEs are done in the office. And so one of the ways you can do this procedure in an office-based setting is have an adequate pain regimen. And one of the most important pieces of that pain regimen is intraarterial lidocaine. Now, some people, based on the experience of chemoembolization, would do the lidocaine first before embolization, or mix the particles that they were embolizing with lidocaine and then do the embolization. And both of those techniques should not be done. And the reason being is if you do the intraarterial lidocaine first, you run into vasospasm. And if you mix the particles, eventually you'll get vasospasm too, maybe not right off the bat like you would if you start there. But once you have vasospasm in the uterine arteries, you've kind of destroyed your endpoint. You don't know where you are. You will absolutely under-embolize this particular side. And so we wait until we're finished. And then once we're finished, fine, you're going to get arterial spasm. So what? I mean, it'll take a little longer to get the 5 cc's in. You won't be able to just straight inject it. You got to take your time. You don't want to reflux it. So it's a slower injection, but you will have adequately embolized somebody and not destroyed your endpoint. So that's really important.
Yeah, that's interesting. So what about so I have 2 questions about that. One, why is it lidocaine and not a anesthetic that has a longer half-life that's used? Because conceptually you'd think, those would prevent pain for a longer amount of time.
Sure. I mean, I think there probably have been some people that have used, say, bupivacaine, which is a much longer acting agent. I've not used bupivacaine intraarterially. But what the intraarterial lidocaine does, I think it was used because of the familiarity in the other, say, with chemoembo and our familiarity with using intraarterial lidocaine. It was just an easy thing to do. We've used it in other areas. But what it does do when you do it for a UFE, most of the pain that somebody feels pain will peak around kind of 6 to 8 hours post-procedure. It starts immediately if you don't use lidocaine. And so, when we first started doing this years ago, or even more recently than that, by the time the patient was finished the second side embo and they were on the gurney heading back to their room, the patients were already in pain.
Yep.
We don't see that anymore because that's what the lidocaine kind of takes, that first 6 to 8 hours of the pain curve away. And so, the patients will have pain afterwards, but you've kind of taken that first 6-8 hours of it away. And it really has totally changed the pain curve for patients and has been, a very significant breakthrough. There are other medications that are also helpful.
Yeah.
We use IV Tylenol. That's been very helpful, and along with a very standardized kind of pain regimen with obviously narcotics and anti-inflammatory medication, the combination of which has worked really, really well. So the number of people that really have a lot of pain is dramatically reduced. We still see it occasionally, but fortunately it's a much rarer occurrence because of these things that we've been able to add to the armamentarium.
Yeah, you mentioned IV Tylenol. I've seen some UFEs where intra-arterial, just like the lidocaine or in place of the lidocaine, an NSAID is given intra-arterially. Is that pretty common, or what are your thoughts on that?
It's very common that I'm aware of, but I know that there are people using it, and there are more and more people that are using, blocks, for pain control and swear by that. And I've done a few of those, and it does work. But it takes a little time, and there's a learning curve on the procedure.
Yeah.
And you want to absolutely make sure if you're doing those blocks that you're absolutely not intravascular. That can, cause seizures and other problems. But
yep.
A good block, and if you're very facile at doing it, is a great way to avoid a lot of the post-procedural pain also. So if you want to, there are a lot of places that are moving in that direction, and that's great. I mean, you have to find, depending on where you're doing this procedure, whether you're doing it in the office or an outpatient lab, or, you have to figure out what's your environment, what are you comfortable doing, what are your capabilities, and any way that you can make it an easier, safer procedure for the patient is great.
Yeah, definitely. It seems like too, with using a block, you'd have a higher overall level of lidocaine if you're also doing intra-arterial lidocaine, right? With higher risk of seizures.
Well, you just got to make sure you're not, when you're doing the block, you just can't be intravascular. You just want to make sure when you're injecting, it's not intravascular. And you test it with contrast, and you make sure that you're not intravascular, and that hopefully the needle doesn't move, and then you can do a successful block, and it works great. But we felt these other techniques were, for us, quicker with less risk and downside.
Definitely.
So, Dr. Lipman, we talked about the pain management intraoperatively. Can you tell us a little bit about the post-op and what the typical treatment response is for the patients?
Sure. We give patients a narcotic. I like using oxycodone, and I use plain oxycodone because I've given patients typically 2 doses of intravenous Tylenol, one at the very beginning as soon as they kind of come into the center, and one as they're leaving. And so I don't want to give any additional Tylenol, it's why I don't use Percocet. I just use plain oxycodone. I'll also add 5 days worth of prescription strength Motrin, so 800 milligrams every 6 hours for the next 5 days. I'll also send them home on a stool softener, because the narcotics are great, for pain relief, but they're very powerful constipators. In fact, probably 90% of the phone calls that I'll get after the procedure is usually around day 3 or day 4. Patients will call with pain, and they're all, when you ask if they've had a bowel movement since the procedure, none of them have, and it's this kind of ileus from the narcotic.
Mm-hmm.
And so we'll send patients home on stool softeners and try to get them to aggressively push fluids at home. And then lastly, we send them home with a suppository for an antiemetic. Phenergan suppositories are also helpful. And we'll have them take one of them as soon as they get home and have them put it in their rectum, get it on board. Even if they're not nauseous, it gets the stuff on board, which is helpful it often makes people drowsy. And that first afternoon and evening is the most discomfort that a patient feels. So the more that they can sleep, the less they're feeling.
Great point.
Gotcha. So what's the typical follow-up care for these patients? When do you see them back in the office?
Well, I will speak to them every day by telephone. The nurses will call every day until they get through, the post-procedural period. Typically, it's 5 to 7 days. Some people respond quicker than others, but that's a typical recovery. And then after that, I will see every patient in the office at 3 months. And at 3 months, we're hoping for two things. We're hoping, one, when we go down the list of patient symptoms, the heavy bleeding, the pelvic pain, the urinary frequency, what have you, they're saying that it's at least significantly better by then, if not OMG better, but at least significantly better. And then we're also hoping that all the fibroids are infarcted on the contrast enhanced MRI. And if those two things are in place, likely, particularly if the patient is over 40, I'll never see them again. And that's great.
So it's a combination of asking the patient where they're at symptomatically and imaging in order to determine the success or lack thereof.
Yeah, the success is based on symptoms. It's not about how much the fibroid shrinks, although that's great. We always love when the fibroids shrink dramatically. It makes for great pictures, and certainly the patient is thrilled with that. But it's all about symptoms, because if, the reason for doing the procedure is to improve the patient's quality of life. It's all revolved around symptoms. And we use 3 months because it takes some time for that to occur. And, the first period that somebody gets after the embolization is really a wild card. It can happen at any time. I tell patients, you could have had a period end the day before the procedure, and the next day after the procedure, you get another period. Typically, the first period is better, but don't get discouraged if the first one isn't. The second one will be, and the third one even better still. So I'm looking for this trend of significant improvement in their menstruals and in their quality of life. And then we look at the imaging in the hopes that we'll see that all the fibroids are infarcted. And say, typically that's the case, but there will be patients, and this is why the UFE is not 100%, but more like 90%. There will be a small percentage of patients where they'll come in to the office and their symptoms won't be significantly improved. They're not any worse, but they can't tell they're significantly better. And then we look at the MRI for clues, like, why would that be? That's unusual, that's odd. Let's look at the MRI, and those patients you'll see, say, the dominant fibroid will still be enhancing on that contrast enhanced MRI. We'll know then that we cut off the uterine supply, but in this case, likely they have an ovarian contributing to the dominant fibroid. And so if the fibroid is still alive, it still causes symptoms, and the patient can't tell they're significantly better.
So at that point, is there ever the idea to go back in and try and re-embo?
Yes. In fact, that is an option for them. They can consider surgery at that point, or I'd say more likely the patient is open to getting, the ovarian embolized. Now, as long as the patient is not interested in fertility, you can embolize and do an ovarian artery embolization. But in somebody that is interested in fertility, that really isn't an option for them. But fortunately, this scenario is an unlikely one, but there are some patients that we will do a second embolization for those ovarian collaterals.
Before you mentioned adenomyosis is something you can treat as well. Is there a difference in follow-up care for these patients with adeno, either with fibroids concomitantly or exclusively adenomyosis?
No, the follow-up's the same, and it's a little bit harder to treat adenomyosis than fibroids. The success rate is a little bit less, although using the smaller particle size and the more aggressive endpoints, we're approaching the success of fibroids, which is great.
Wow.
So the more we're learning about this, the better we're getting at knocking out adenomyosis. And with adenomyosis, unlike fibroids, where there are a number of different options for patients, there are really only two good options for patients with adenomyosis: either embolize them or hysterectomy. They've tried other progesterone laced IUDs or other hormones that just doesn't work. And so patients really are with adenomyosis are stuck. I mean, fortunately, embolization is getting better and better, and it's worth doing because for the most part, most patients will be able to avoid hysterectomy. But those are the only two choices available for adenomyosis.
Interesting. So you mentioned the collateralization. How often are you seeing ovarian collateralization or other collateralization that you either have to treat during the procedure or in follow-up?
You'll see at the time of the procedure, you'll see ovarian collaterals from time to time. It doesn't mean you have to embolize them, however. And so you will, when we do a UFE, we'll start with a pelvic run, a pelvic angiogram with a pigtail, not too far from the bifurcation. And sometimes you'll see an ovarian on one side or both sides. But, we will obviously notice that and take it into consideration. Okay, we see that she's got an ovarian there, but it's not until you're actually selectively into the uterines that you can, you really have an idea of whether it's going to matter or not. Because a lot of people can have these ovarians, but you will embolize still through the uterines to a degree that it's completely satisfactory and everything is perfectly knocked out, and you don't have to address the ovarians, versus when you do a uterine embolization on one side and you know that there's, say, a big fundal fibroid on one side, you do your angio, you see the say it's on the left side, you see this big left fundal fibroid, and then when you select the left uterine and you do your run and you start to embolize, if you don't see, the blush and the embolic going up to that left fundal region, it's kind of this bare area. When you inject contrast, you opacify all these vessels from the other fibroids, but you don't see the left fundal one or as much as you should see. So you can infer that the reason why it's bare and not opacifying is it's getting fed from an ovarian from above. The ovarians come off up, by the kidneys, and sometimes off a renal vessel. And so at that point, when you see that it's bare and you're not filling it with embolic or contrast, we will finish that side and finish, the embolization of the uterines, and then swap out for the pig and put it up, by the second lumbar pedicle. That's usually where the takeoff of ovarians live, at L2 pedicle, and then do a run and see, now that you've done your uterine embo, are you still feeding from ovarian collaterals? And if so, then you decide to embolize either one side or occasionally both ovarians if necessary, to get to the right endpoint. But again, this is not a common scenario, but you'll see the ovarians more commonly than you'll have to do anything about it, because you can kind of reflux it a little bit into the ovarian, and then the ovarian takes it out to the fibroid. So you can kind of use the ovarian to kind of deliver your embolic, even though you're in the uterine artery.
Oh, I see. Interesting.
So because there's, communication, and you can we do like a little reflux to and fro. You kind of inject and you're watching, and you see it kind of go up the ovarian a little bit, and then you stop, and then that ovarian flow takes it out to the fibroid that's being fed off ovarian branches. So even if there is ovarian supply, you don't necessarily have to, catheterize the ovarian from above and embolize it. You can kind of do the work from the uterine below.
Are there any other collaterals that you've seen exclusively feeding fibroids, like your example with the fundal fibroid and the ovarian?
Well, you'll occasionally see, there are some external branches that might feed a fibroid, say in the broad ligament. We'll see that. So you have to kind of, you might have to inject, external iliac artery branches looking for it. On a very rare occasion, you'll even see branches off the IMA.
Oh, wow.
So that's really rare. But fortunately, for the most part, almost everything can be done from a bilateral uterine embolization. I mean, you'll sometimes see patients that don't have uterine arteries, and everything comes from the ovarians. So, you'll do, there's just no uterine to speak of, or maybe like a little cervical vaginal branch on each side that you're not going to embolize because that's not part of the perifibroid plexus. In those cases where you see either one or both sides with a very gracile uterine vessel, you know that you're going to have to go up and look for ovarians. And then hopefully they're not interested in fertility and you can embolize the ovarians, because otherwise you'd be stuck.
So one of the principles that I've seen that is important with embolization in general and with, understanding collaterals or arterial supply is it seems that as you embolize a structure and you get that stasis, in fibroids, that if you do a run afterwards, a fluoroscopic run, you might see more collaterals than you did before, but that's sort of like a super physiologic collateralization, either because of the flow and also because of the distal embolization. In those situations, are you conservative in saying, oh, this is collaterally supplied and we need to do something, or versus, oh, this is just super physiologic?
Well, we embolize, we want to make sure that we're knocking out the perifibroid vessels. And then once that happens, you will often see vessels that you never saw before, as there's kind of a shift in flow to normal myometrial collateral vessels. You don't want to embolize those. So if you start to see those, that's a good hint that you need to, stop your embolization. You've reached your endpoint. So you're looking at slow forward flow in the main uterine artery, and then also for the presence of these, normal collaterals. You don't want to embolize those. You're just inflicting more myometrial ischemia, which results in pain to the patient.
Yeah. It kind of goes back to your original principle you said of not just shoving as much embolic in there as possible.
Correct.
Interesting.
Correct.
So another question I wanted to ask is about IR education in general regarding fibroid treatment. And I know that in some places, the relationship between OBGYN and IR at the institution isn't as positive, I guess you could say. So the amount of fibroid embolizations that are being done is lower at some training institutions. Do you think that would put a resident or a trainee at a disadvantage versus, once they get on the job, they'll be able to learn, like it is in some other modalities or some other treatments?
Well, anytime you can get as much experience in your training as you can, it's going to benefit you. If the relationship between OBGYN and IR is contentious, I would say start with the low-hanging fruit. There are patients that gynecologists don't want to operate on that are suffering with fibroids. You could offer to do those. There are patients that you could work together on. For instance, if a patient has multiple fibroids in their uterus causing symptoms, and one of which happens to be in the cavity of the uterus and happens to be bigger than, say, 3.5 centimeters in size, you could do what's called a combined approach, where you can embolize the patient first, and then 2 to 3 weeks later, the gynecologist can do the hysteroscopic removal of that one intracavitary fibroid. And so you're working together because they don't have a good solution for that patient.
Yeah.
Because there's so many fibroids and this one in the cavity, they would have to operate on the outside as well as operate on the inside. You can do 2 non-surgical procedures, the embolization to knock out all the fibroids. And as I say, they can come in and very easily remove hysteroscopically that one fibroid because it's infarcted. They love that. That's a really nice procedure because unlike a living fibroid, which can be challenging to remove hysteroscopically for some, a completely dead infarcted fibroid is very easy to remove. And they love the simplicity of it. It doesn't bleed at all.
Yeah, it's a surgeon's favorite thing.
Right. So it's a nice way to kind of cooperatively tackle this patient non-surgically together.
Yeah.
You could also try other types of women's patient, female patients that they may not be interested in treating. They may see patients that have migraines. They may see patients with varicose veins, and they don't have anything to offer these patients, but women will come to them with these medical issues that they don't have anything to offer them. And if they know you do, that's a nice entree into women's intervention and women's health that we do. And you can then work on fibroids. If they see how good you treat their other patients, maybe they'll, they will warm up to the fact of maybe they can help me with fibroids too.
Yeah, that's amazing. I think the whole idea of practice building and even trying to attempt to do that in your training as much as possible to improve relationships is great. And I've seen this work to a certain extent with postpartum hemorrhaging, with IRs that have helped with those patients. And obviously, that if you can save OBs, or if you can save a patient period from hemorrhaging, that's great. But that obviously would improve a relationship as well.
Definitely. And I think we need to be thought of in that scenario more often than we are currently. In fact, when Phil Mickelson won the Masters the first time, his wife was actually saved by an IR for that very reason. And they fortunately knew about IR's capabilities, but so often they will keep trying to go back to the OR and keep trying to pack, and the patient's going down the tubes. And they just don't know that the IR could help them under this scenario.
Yeah. The first postpartum hemorrhage case I saw was exactly as you just described it. And it was a scary case. It was scary to go up to the OB floor and see this patient who had lost over 10 units of blood, and had been transfused many, many more units of blood. And then you go in and you embolize in a similar fashion to a fibroid embolization, and you see, but with gel foam, obviously, and you see this marked response. It's amazing.
Yep.
Well, great. So, is there anything else important for listeners to know about the care of patients with fibroids that you want to leave us with?
Well, I think that because your audience is a lot of residents and medical students, I think the most important thing is to consider interventional radiology as a field of practice. As I say, I think it's the coolest field in medicine, and a lot of programs get very little or no exposure to IR, and I think that's a real shame because it's a phenomenal field of medicine. It's cutting edge without the cutting. We're in every organ system in the body. We can offer these non-surgical solutions, and we're often the go-to person now for, say, intracranial aneurysms. Which is phenomenal. Back in I trained long ago. Instead of having to shave a person's head and drill holes in their skull and try to put this little clip around the neck of the aneurysm intracranially, you can go up from the inside, and a patient gets treated with GDC coils, and they go home after a brief visit. They get a Band-Aid. It's incredible. We're treating conditions all over the body non-surgically, and it's a great field of study. And I would encourage your listeners to, give it a shot, particularly if they're medical students and they still have, time in front of them where they're evaluating where their career's heading.
Absolutely. Yeah. This is just another great example of a treatment that can be done and can be approached clinically in interventional radiology that can really make a big difference in the whole medical field. So we appreciate you.
Yeah, we're on the front lines in, you mentioned critical limb ischemia and peripheral vascular disease, stroke, AAAs, abdominal aortic aneurysms of all variety, intracranial, extracranial, oncology. There's great work with a whole field of interventional oncology now.
Yeah.
So there's all sorts of subspecialties, within IR, like ours in women's health and fibroids. But You can find your niche. And I think that's, how we take back medicine. I mean, so many people I see at medical meetings they're this physician burnout, and they're just kind of fed up with how medicine is kind of where their career is headed. And, I flip the coin and I say, how do you want to practice? And you just make it happen, and you can do it. I've done it. And it's, I think this way of practicing medicine in the outpatient arena, and very specialized with people that have high volumes and high expertise, is really the way you want to be treated. And I think, we're hopefully getting more people on, thinking like that, so that we can really bring medicine back to the patient and physician. I mean, that physician-patient relationship is what's been lost, and you can find your way back if you have a practice like this. You really can.
Yeah, absolutely. We appreciate you coming on the podcast today, Dr. Lipman. This has been a phenomenal interview, and I think our listeners are really going to enjoy it. So thank you.
Oh, well, it's my pleasure. I thank you.
Yeah, it's just been amazing hearing how you've made such an amazing clinical-oriented practice and just impacting the lives of so many women. It's just been great sitting back and listening to you talk about it. So thank you so much again for joining us.
Oh, it's my pleasure. And if anyone, we see a number of medical students, residents. I volunteer in the OBGYN department at Morehouse here in Atlanta, but
awesome.
we've had physicians visit. I had a physician earlier this year from Korea, one from Australia. We see medical students. I had a medical student from University of Maryland a couple of weeks ago. So we see medical students, residents, physicians from all over spend the morning, spend the day with us. We're happy to do it anytime. So anyone listening wants to come and see what UFE is all about, we're happy to have them.
We'll be sure to include your information, as we said, in the show notes. And thank you again, Dr. Lipman.
My pleasure. Thank you.
That's it for this episode.
If you'd like to learn more about Dr. Lipman and his practice, you can find him on Twitter at Dr. Lipman1 and Instagram at Dr._Lipman. The Atlanta Interventional Institute website is atlii.com. You can find these links as well in the show notes for today.
Please keep an eye out for our upcoming episodes this season, where we'll be discussing the Interventional Radiology Interview Trail, Interventional Oncology, Palliative Care IR, and more.
If you have any questions or feedback, we'd love to hear from you. If you're a practicing IR who would like to get involved with the podcast, please contact us at our email address, thesoundofir, all one word, @gmail.com.
You can also follow us on Twitter. We're at the_sound_of_IR. If you enjoyed this episode, please feel free to leave us a rating and review on Apple Podcasts or any of your favorite podcast apps. See you next time.